Refai, can
Hello, sir.
Refai.
Dr. Pradakma, sir. Dr.Refai here.
We have Ramesh Dugapati, the man which is actually
Good
everybody
morning,
is
Dr.
looking for.
Ramesh.
Good morning. Good morning.
Dr. Sunil Modi, Dr. Kayur Parik, Lekha Parak, madam. So we can actually, you can present your case and go ahead and enlighten
Sure.
us.
Sure. Thank you. Thanks for the organizers, particularly Dr. Srinivas Kumar, for giving this opportunity to present our case. So before we start, I'll just introduce my team. I have Dr. Radha, who is my associate junior consultant working with me. And then we have Mail and Bala as our technicians and Ramus as our scrub nurse. And we have runner nurse Pragati and Gopi with us. And we have the Abbott OCT team with us as well. So let Dr. Radha talk about our case to start with.
Good morning, everyone. Here we have a 53-year-old male who is a diabetic, hypertensive, and dyslipidemic. He underwent CABG in year 2010 with 3 grafts, Lima to LAD, and venous grafts to diagonal and major OM. The LV function was normal at that time. Now he presented to us with effort angina for the past 2 weeks. The ECG was within normal limits. Echo, there's no regional wall motion abnormality, and the LV function was normal. He underwent a CT angiogram which showed densely calcific distal left main and osteoproximal circ and LAD disease. It's a Medina 111. There's around 70 to 80% plaque burden in the distal left main and also the osteoproximal LAD. The circ was also severely diseased, and mid-RCA had around 50 to 60% stenosis. The graft angiogram showed occluded Lima to LAD graft, but the venous grafts were patent. Here in both the panels, we can actually see in the right panel, the dense calcium at the distal left main extending into the LAD. And the left panel, which is a contrast, shows us the filling defect in view of the severe stenosis in the osteoproximal LAD also. So this is the coronary angiogram we have done 3 days ago. So we have an LAO caudal on the left panel, which is showing calcified distal left main and osteoproximal LAD with around 70 to 80% stenosis. Also, the proximal circ has got severe disease. In the RAO cranial view, we can see that it's a tubular atheroma extending all the way from distal left main up to the mid LAD. The RCA seems only moderate disease at the distal RCA. There's a focal lesion, which is around 60% stenosis. And here we have 2 venous grafts, which are nicely flowing. The first one is the diagonal graft. And then we have the OM graft, which is also nicely filling. So the plan here is to go for imaging, assess the calcific burden, and then decide upon the calcium modification strategy, and then proceed with the PCI.
So that is our case we presented to you, and we've shown the angiogram. Let me just ask the panelists to feel how you go about this patient's PCI strategy.
Dr. Sunil.
How would you approach this, Dr. Modi?
Okay. Left main to LAD, obviously. And again, after pre-dilatation, maybe I'll prefer OCT because that calcium and all can be better judged by, and be prepared for some ablation strategy, rotablator or anything new, whichever you want to use. So because we have experience of rotablator far more than these newer ones. So in case it is required, then I'll go for rotablator first.
Okay. All right, Refai. So you heard, I think number one question is who's the surgeon and where was it operated? Because Lima went down, and why did it go down is my curiosity, and the vein grafts are patent.
I was actually, when Ramesh asked this question,
I think the
deliberately
CABG
avoiding that.
6 years ago, and I'm not entirely sure whether around 2010, maybe around 11, 12 years. I'm not entirely sure that the Lima went down very earlier on, and he was just living on the LAD, and now the disease has progressed and he's presenting with symptoms, or the Lima occlusion is very new. Because when I looked at the pictures, what we can see is the Lima is not occluded from the top. I think there is this little flow into the first 10 millimeter, and there's nothing after that. So I'm not sure very clearly what exactly, but the typical symptoms are only within the last few weeks.
Oh, all right. So I agree with the plan that probably first do imaging, and then we can decide on how to approach this. Is that right, Dr. Parikh and Pratap?
Actually, he already done OCT. Now the question of no imaging, OCT done. So you have to show me the OCT picture.
Yeah. So
Right.
what we did is we just tried radial axis with a 7 French slender sheath, and we put an EBU 3.5 7 French guiding catheter, which I do for all left main, and we just wired the LED, and then we done an OCT image without ballooning. So the first OCT was done without any balloons. Next one. So we'll show you the OC. So this is the first OC. Yeah. By the way, I also, because distally the LAD was, there is a tight stenosis and this distal flow was not very good. So I used a 1.5 balloon inflation gently to make sure the LAD flows very smoothly, because when the wire comes back, I want to make sure the wires go smoothly than before. So I just ballooned it, and after the balloon 1.5 dilatation of the distal LAD, you can see it's a good flow. I may consider a DCB at the end, but for the time being, I just ballooned the 1.5 millimeter balloon to the distal LAD. So this is your RAO cranial view, and then we got the OCT down. And shall we show the OCT images? This is the first OCT before balloon dilatation. As one would expect, the stenosis was tight enough that we could not get a very good clearance at the distal part of the OCT run, which is the mid LAD, whereas the interest was mostly in the proximal LAD and the left main. As you can see, the amount of calcium seen on that OCT run. Now you can see clearly the proximal LAD coming back into the left main. There's one spot you can see a circumflex ostium around 11 to 1 o'clock. Yeah, there you go. Just drop that. And this is the distal left main is also diseased up to around 10, 12 millimeter, well, around 6 millimeter, and the large left main at the proximal segment. So we measured the sizes.
So, Refai, can you tell
Yeah.
Mile to show OCT on a bigger screen? Just one
bigger screen, please. Can you show it on the bigger screen, the OCT?
OCT.
Just OCT alone.
Just the OCT. The whole screen should be OCT, not the side fluoro
No
images.
no images, no photo of Refai, only OCT.
Only
OCT. I don't think they are not showing
We don't
OCT.
note for profile pictures now, is it? So
Yeah.
just OCT pictures. Fine.
So, I mean, I agree with the plan to pre-dilate and do OCT again. And I think that's much
That's
more
right.
important to look
No,
at.
can you show the OCT images in
Yeah.
the
The first
calcium?
OCT of the calcium
Yeah.
images on a big screen. Can we put whole screen with OCT?
If not, we'll turn back.
Okay, okay.
Yeah. I mean, clearly there is evidence of calcium, and the lumen size is decent enough. And the left main, I have to come back all the way, at least 8 millimeter from the carina for the left main, maybe 6 to stop my landing of the proximal landing of the stent. But clear ostium looks clean from the angiographic images. So that's one of the reasons why I went with OCT rather than an IVS. And thankfully, because he's got a graft to the OM, I'm thinking of treating this as a single vessel long segment stenosis without going for any bifurcation strategies here. I guess what is the opinion from the...
Refai, actually, we wanted to know that what is the thickness of the calcium, whatever you have seen.
That's
It
right.
is
So there
more
are,
than-
I guess stop. With the thickness of the calcium, is around, definitely there are segments which is more than 500 microns. And
So
length is definitely more than 5 millimeter in
Okay.
certain parts of the calcium. You can see there. And the arc is not 360 except for one focal spot. So the
Okay.
calcium score, if you're interested in, is around 2. But having seen that, I mean, I think I heard the discussion about cutting balloons, scoring balloons. I have a different perspective on it. I may just put it up here that I tend to, as we all know about the cost of the cutting balloons, I tend to use a 1-to-1 NC balloon to look for expansion in 2 orthogonal views. And if it's nicely opening up, then I would rather stent it without using the cutting balloon. Because we all know from the data, you look at the EBC main, Rolex, all these left main data, the use of cutting balloons is less than 20%. Any calcium...
They actually lose less cutting balloon than scoring balloon, and they sent these type of patients for bypass surgery. So that is not a question here. Whether cutting
the
balloon is
EBC main
effective-
study,
No.
which looked at the comparison of provisional arm with the 2-stent strategy arm, or the Rolex registry, or the DK Crush V study, which is the most common studies. We talk about left main PCI. If you look at the cutting balloon usage in both the arms, not just one arm, both the provisional, and they're all ages of around 70s, mid 70s. Patients are not very young, and you can see they mentioned about moderate calcium calcification, severe calcification. There's a decent amount, around 60% had at least moderate calcification. But if you look at the supplementary and look at how much of cutting
No,
balloons.
actually,
rotablation-
Rafai, we
Yeah.
should not move away from the case, otherwise you'll be in trouble.
Sure. Anyway, so
actually
let me
our
just go to
point
the
is-
next picture. So I used a 2.5 balloon dilatations. Let me show the angiogram.
We want to
about
see
the-
your face also now. They are not showing at all your face.
They're not
Please.
showing my face.
Okay, good.
Sorry, so see, the decision was where to stop my distal edge of the stent. I think we have a decent space of around 2.75, which I'll show in the next OCT after ballooning. So I used a 2.5 balloon to pre-dilate.
You use
and
a
then-
balloon, you use the NC balloon in this case because
Yes.
your atherectomy is not required. You are not a strong believer of cutting balloon and scoring balloon. It's okay. So you just used an NC balloon and created, you did one more OCT after that?
I did. Shall we show the next OCT after, and you'll see the cracks and ruptured plaques with the normal NC balloons, which are going to running on the screen now as we speak. So would you agree that there are some decent cracks and disruption and dissections of the plaque?
Yeah, we agree with that, Refai. I wanted to ask any questions from the audience. Please use the mics and come on and ask us. Dr. Parikh, I wanted to ask you specifically a question. Antonio Colombo has been showing live cases of a drug-eluting balloon alone strategy for such LADs even. What is your thought on that?
Drug balloon.
Yeah, we have been using drug balloons, but not in these cases, mainly in mid to distal LADs, 2 millimeter diffuse diabetic disease side branches. So though Colombo has been promoting, I think we don't have data to make it a practice.
Right.
And this is a great case for very good stenting. We would, however, I use scoring balloon. I use angiosculpt.
Right. The only question, the reason I was asking about that is the distal flow, Refai, is not so great, right?
Yeah, the distal LAD. I may show you the last picture after ballooning. We took one picture after ballooning.
Okay,
Sorry,
good.
the screens are not clear for you. The next one will show. Back one. Yeah. This is the OCT run. That's because with the OCT, I may take one run in the cranial view to show without the OCT catheter how the distal flow is.
Maybe give
Before
some
we
nitro. And,
We have around 200 and the brushes are okay. So we can do another 200 of nitro, please.
Sure. Okay, so Dr. Pathak, what you would go with the cutting balloon?
Discuss what are the ways to handle a calcified lesion in today's era. We talk about rotablator, rota and rota. Is
Yes.
there alternative technology for calcified lesions?
So I was
Just, I want to ask the Prafuma.
Madam, actually, in this case, you can lot of devices are available. You just go to the atherectomy part. That is why I asked the score. If the score is more than 3, then you have to go to atherectomy. Can be orbital atherectomy or rotational atherectomy. If you use a balloon, you have multiple balloons available, not only cutting and scoring balloon. You have OPN balloon available, you have IVL balloon available. So these are the 3 things available now. That all depends upon the lesion can be taken. Usually, sometimes the calcified lesion, no device can be taken. So you have to do a rotablation, create a lumen
23.
enter these devices. After the lumen entry, both IVL as well as OPN balloon are bulky balloons. In that situation, the cutting balloon is easier to track than these devices. And not only cutting balloon and scoring balloon.
Successful in this.
Yeah.
Definitely. The correct
So
manner.
the Eclipse study is looking at, actually, we don't have the data to support anything yet, but OCT score is low here. There is no need for rota or orbital atherectomy.
This case is no, because definitely that is why I asked the score. It's actually less than 2 and there is no problem. You can just go ahead with devices, balloons, whatever balloon you like, and can create a luminal gain and then go ahead with the case.
So Refai, go ahead and show us what you have done so far.
So the next OCT run you may have seen. Can we play the next second OCT run to show? And just what we decided is the distal reference diameter is around 2.6, where I'm going to land the stent just above the large septal branch. So that is my distal landing zone. So and then we measured the length. We decided to put 2 stents because the left main is around 3.5, 3.9 rather. So we decided we'll put a 275 2.75 for the mid LED, a short 23 millimeter stent, and then we will probably put a 18 millimeter 3.5 stent from the left main into the LED, and then go with high pressure ballooning of the port. Now I got a port space of around 6 to.
But Refai, you told 2.65 is the EL to EL size, and how do you take a 2.75 stent?
Because my proximal LED is a decent size. This is a 23 balloon, so I've decided I can even put a small.
You tell that is a fallacy of the interventional therapy recommended by the OCT people. They tell that 0.25 less than the EL to EL to be the distal stent size. You are telling I will take a 0.15 more than the EL to EL. Then you are telling that is it acceptable? Actually, by the 2.65, you have to go for 2.5.
No, I'm just going to put a 2.75 because there's only a very short segment, which is around 2. If you just play the distal segment of the OCT run, and then we have a size is decent enough. Yeah, so show me the
3.9. You're going to take a 3.5 stent from LMCA to proximal LED and then
correct.
Dilate with a 4 millimeter balloon. Ramesh,
Correct.
will you take a 2.75 or a 2.65 stent in this case?
No, I mean, I definitely think it's a 2.75 vessel. There should not be any LED that is.
Actually, then when you do imaging, you have to follow the image.
That's true.
Otherwise, why do you do imaging? I will take a 3 millimeter stent if I don't do an imaging in this case.
Right.
If I do the imaging, I'll be in a trouble situation. Even then, I will actually follow Refai. I will never take a stent below 2.75. This is actually our conscience do that.
No, but and also we know that OCT actually undersizes the stent.
But they are telling that EL to EL 0.25 less than the EL to EL size. Any comment from the audience for that?
Okay, I think Doctor, we'll take few comments, and Dr. Refai, you're going to show or then we can go back to the other center and come back. Any comments from our audience or anyone from here? I think Dr. Modi.
No, I'm just wanted to ask Dr. Refai, is he using angiosculpt or?
No, he's not using angiosculpt. He used one-to-one balloon. He showed the post-balloon OCT.
And no ablation strategy, no rotablator, nothing. So
it doesn't need
1:1 balloon and then followed by stent.
Yes,
okay.
Because the
actually atherectomy is not required, sir.
Not required.
That every calcified lesion does not require a rotablator.
Of course not.
No, man.
Of course not.
So Ramesh and Pratap, it's me here, Ashish. So,
Ashish.
So let me just tell you, I mean,
please.
So by using a 2.5 stent, you're not committing to a 2.5 diameter. You have the luxury of going up with an NC balloon of whatever size you want, especially if you're using stents that allow you to do that, like the current generation of 3rd and 4th generation DS, especially if you use Synergy or Onyx or whatever stent you use. The point being that you use a 2.5 and the undersizing is primarily meant to 2 reasons. 1, to prevent an edge dissection, and 2, to give you the flexibility of going higher with an NC balloon after you image again, and 3, reducing the risk of perfs, especially on angles.
Keep it at 10.
So hence the conservative Abbott and algorithm that Ziad proposes.
Right.
There's a logic behind it.
I mean, I agree with you. You can't oversize, you can't undersize the balloon, but you can put a 2.75 at 8 millimeters, which will still give the same thing. I don't think that it is a big deal in my opinion.
No, not big deal. But I'm just telling for the discussion part we are doing. If you wanted to take a single stent also, I can take with a 3 millimeter long stent. I would just go, even the nominal is 8 or 9. I just go 6 and then come out. Proximal part, I dilate with a high pressure of 4.5 millimeter balloon, and distal, I just go with a 2.75 in a 3 millimeter stent and then do an imaging. Then understand no edge dissection. You can come out with a single stent strategy also.
4, 6, 8, 10, 12.
So looks like Refai already used the stent and the middle edge.
So I put a 2.75 by 23 Zions Alpine and went up to 12 atmospheres, which is a nominal, 10 atmospheres is nominal. And I've just pulled back to open up the osteoproximal part of the stent and also the lesion in the left main. So the only thing I haven't done yet is I haven't used a 3 balloon in the left main. Now I would ask the panelists, would you prefer to use a 3 balloon before take a stent, or would you be happy with this 2.75 at 16 atmospheres, nicely opened up, and get the stent into the left main. I think this is always in my conscience, I always the discussion, use another balloon, or are you happy with this balloon going high pressure and then put a stent when we know that the calcium has been cracked. So I just want to know what the panelists feel about it before I take a picture while we are removing and taking the picture from here.
Yeah, I mean, I think it's okay to 275 at 18 will probably give you what, 2.9 millimeters or so.
Definitely will get it. The same balloon can be used. Otherwise, you can take I will not take a 3 millimeter. I will approximately take a 3.5
Sure.
and create a very good luminal area and then take a stent. Because always preparing a lesion or pre-dilatation is better than the post-dilatation. That is always my concept. Because
I think that's a very valid point, because sometimes we get caught up with this 2.7, because remember there's a stent balloon and it won't go very high. Even if you go, it's around 3.1, it goes up to 22 atmospheres. So the question, as you rightly said, so we may use a 3.5 balloon, a 12 balloon to prepare it, make sure that it's fully expanded before we take the stent.
Yeah, Pratap
I
still
think that I
wants
will
a
agree with
cutting
that.
balloon
Exactly.
there.
No. I actually, Refai is opposite too. So we are going to do a study where the opposite arm will be Refai only. So we'll go to the
No, it's
first
not that
and
I'm
come back.
against it, but it's just the exotic cost of it makes us to think before we do deliver devices. Unfortunately, that's the only reason. It's not. I'm sure the circus wire is coming back. I'll just push this.
Okay, Refai.
I agree,
Yeah.
Rafai.
Ramesh wanted to go to the other lab and come
please.
back. Okay.
Thank you.
So we will go to Refai.
Yeah, Rafai, we are back with you, Rafai.
Yeah, so let's go back to pictures where we stopped. We deployed the mid LAD stent at 275 by 23 millimeter stent. We deployed back one. And then we all agreed that we'll use a 3.5 balloon to pre-dilate the ostial LAD and the proximal left main. Back one, back, mile, back. Yeah, so that's the one. Yeah. So this is the 3.5 by, this is stent. Back one. So back one. So essentially we used a 3.5 balloon as we all agreed that we'll go high pressure just to make sure that we opened up the lesion properly before we deploy a 3.5 stent. So I went up around 12-14 atmospheres with 3.5 balloon. Next one. And then we went up with a 3.5 by 18 Zions Alpine into the left main to LAD. Next one. So I deployed this around 12 atmospheres. Next one. With a landing port of around 6 to 8 millimeter. Next one. So this is the cranial view to expansion of the stent. Go back one, we'll see the caudal view as well. Yeah, so you can see there is a lot of calcium, adventitial calcium, which suggests that there may be not full expansion. But if you go to the next cranial view, it's fully expanded. Next one. Yeah, and next one. So then what we did is we used a 3.5 balloon to post dilate. Next one. And then we did an OCT run. Next one. In the meantime, we recrossed the wires. Next. And used, this is a pod balloon, 4 millimeter pod balloon at 12-14 atmospheres. Next one. Yeah, next one. So this is where we are now. Next one. So this is what we took after doing a pod balloon and recrossing the circumflex wire. Next one. Even though circ is not very important here. Next one. And then we did an OCT run. Let me show you the OCT run now. So the distal edge looks clean. There's no dissection. We got an area of around 4.5 cross-sectional at the distal edge of the stent. There's all decent expansion of more than 80% throughout. There are some plaque protrusions. Good size stent area in the left main. Yeah, so this is the proximal edge of the stent. There you can see a slight dissection at the proximal stent edge. Show that one. So we have an area of around 9.7. So this is our proximal edge of the stent. Now the length of the dissection is less than 2 millimeter. And there is a mostly intimal dissection. There may be, here you can see the media is still intact. And that is, so I would just like to see what the panelists feel about this. And otherwise, we have a good result in the LAD, good flowing artery. Show the angiographic images. We'll show you the angiographic images, how it looks like, the proximal edge of the stent.
So, Refai, I'm not going to let Dr. Pratap speak, okay?
No, actually, I will not talk
Fair enough.
because he told that I should not. But
Okay. So my question to you was actually left main, even your stent, I was wishing that you used a 23 millimeters come all the way back to the ostium. What would you do, Dr. Sunil Modi, in this patient?
No, I mean, at the moment, I can see some haziness at the, at the ostium of left main.
There's a dissection now.
So is that because of dissection, this haziness?
Yeah, there is an edge dissection at the proximal left
Proximal
main.
edge.
So he did not cover all the way back up to the ostium of the left main. My question to you is, would you always bring the stent back up to the ostium of the left main, or would you keep it in the body of the left main?
I would prefer, most of these cases, unless there is a lot of distance between ostium and the desirable stent, I will like to cover ostium.
Okay, what would you do, Dr. Parikh?
We now routinely cover ostium, except in very focal mid-segment or lesions, but usually these lesions we cover ostium.
Madam.
We should cover the ostium.
Okay, Dr. Refai, I think you need to put a small stent in the proximal.
Yeah,
left
I
main.
would just put an 8 millimeter.
Okay.
That I think
But-
the length of the left main was
You will
quite
sleep
long.
well.
he did not allow me to talk. Definitely, I could. My point of discussion was 2-3 points. One, the ostial part was not pre-dilated with a
4-8.
cutting balloon or a scoring balloon. There actually we could not get a better luminal gain. That is number one. Number two, edge dissection. These are the 2 points which I was focusing in the initial point.
The ostial LAD, can you show what is the minimal stent area? In
Yeah,
that
the stent area, the ostial LAD is around 6.8, 6.9. Do you show that?
Okay.
6.5, 6.5.
So, but still like 10 to 2 o'clock, you see that eccentricity, the calcium, and that's where Dr. Pratap and Dr. Parikh were talking about maybe cutting balloon would have been better. And so I think that's what, we would like to see. If it is more circular, it would probably better. The next question for you, the panel, the distal stent is only 4.5 or 4.75 minimal stent area. What do you think?
That is okay. Only point is actually I'm just going about the length of the dissection, and it's actually edge dissection extending to the media, not into intima. So what is the length of that area, whether it is requiring a
We're going to stent it now. We have to stent that one. There's no left main, you need dissection.
No, I'm telling about the distal edge.
No, distal edge, there's no dissection.
No, there is something.
Can you show, Refai? There's
Distal
no-
edge of the left, the stent. There's no dissection at the distal edge. Remember, this is an OCT, and therefore
only
I thought
left side.
4.7
Okay.
should be okay for a size.
Okay.
MSA.
Dr.
It's not
Pratap,
and it's not a
even if you have
4.81 we
used,
got.
you would have used angiosculpt. Would you have gone to the ostial left main using angiosculpt or?
No, basically, I'm just telling about the ostial LAD part. Ostial
Oh,
LAD,
LAD.
we got an area of 6.7. Now,
yeah.
basically, you should get a very good area in this case.
Then stent boost.
And one question that people were asking, why do you keep a wire into the circumflex in this case? You have a protected
Just over the
OM.
circumflex wire.
Why do you keep a wire?
He
Which-
said just for the fun.
No. Rafai, Ramesh is
No,
telling
the
it's just for
circumflex
fun.
wire I'm taking because I don't want a double stent jailing the circumflex wire. This is more into the ostial LAD and ostial left main. I don't want double stents
No,
holding
Refai,
your circumflex wire when I'm going to put a next stent. So that's why I
his
removed this
question is,
wire.
why do you want a wire first of all in the side branch here, which is protected already?
Right. Okay. There is a small OM at the top of the second OM is where the graft is connected, and there is some flow. So I just left I never did a kissing balloon or nothing. I just left the wire there just for the sake of it, just to make sure there is some flow, whichever that is flowing into the circumflex pre-PCI. I want that flow to continue post-PCI as well. That's the only logic behind
But
it.
the audience sake, I will tell you there is no need of
Stent
putting a wire,
boost.
because actually the wire can cause some perforation distally. And
You
when
go
you
into
just
it.
push the IVS OCT catheters and all, why to create some damage to
One
the
more.
perforation or some complication? Why?
Okay, ready for
So
a test.
tell me, what are you doing now?
Hey,
Yeah,
Ramesh and
so-
Pratap,
You're talking to me, yeah? Take it.
just for clarity, I think it's important to realize that the ostium of that LAD that Pratap was talking about as being not fully expanded has still an adequate cross-sectional lumen area of more than 6.5. And I know there is some concern about it not being completely
Eight
circular, but symmetric expansion has never been shown to be a indicator of TLR, number one, and an area of 6.5, even though maybe less than what you may have gotten if you had used a cutting balloon or some sort of a scoring balloon,
And down.
is adequate. And by any measure, that is an excellent result. I don't think.
Ashish, actually, the recommendation initially was actually 6, 7, 8, 9. That is totally
Use the
gone
same
away.
balloon.
You
Go a
get
little
the
higher.
larger the lumen area is
8,
better,
10.
especially for the ostial LED, definitely. And this patient is actually having a LED is such an important vessel, where if you can get an adequate or better area, it will be always better, you know.
Fine. 14 and
Okay,
down.
that's very good, guys. So
And down.
after your, I think Dr. Refai is stenting that left main now and ballooned it.
Picture.
Or we'll
Uh,
take a final angiogram, then we'll go to
Yeah.
Dr. Goel. Is that okay? Okay.
Can I
Cranial?
ask you,
One more cranial view, please.
All the way down, okay. Center up. Ready?
Yeah, the distal vessel is also opening up.
Open up, yeah.
Thank you very much. Any final thoughts, Dr. Refai, before we let you go?
I think thank you so much for the audience and the expert panel to give some advice about balloons. And I'm sure at the end of the day, the patient will have a good quality of life with whatever we did. And thank you so much for this comments and discussions, which is a good learning point for all of us together, how we treat patients with left main lesions. Thank you so much.
Thank you, Rafai. Thank you. We'll go to Dr. Goyal.